of congenital diaphragmatic hernia, cardiovascular support.
Yes. Yeah, that's not usually presentation. Yes. Yeah. Thank you very much again for the kind introduction. So we have two presentations related to, specifically related to congenital diaphragmatic hernia, which is a big challenge to any neonatologist in any neonatal intensive care. Can you hear me at the back? So my presentation focuses on preoperative cardiovascular care of congenital diaphragmatic hernia. And I think, Ruben, you will be presenting the labor and delivery management and post-operative care. So you have two presentations. Probably, if you are okay, you can do them in sequence. So preoperative cardiovascular care of congenital diaphragmatic hernia. And I will touch a little bit on also respiratory support. We cannot separate both cardiovascular from respiratory care. Yeah, this is just to introduce you our hospital. We have two hospitals in Winnipeg. Where the Women's Hospital or at the Health Science Center. This is the hospital from inside, and this hospital is based on single rooms. One of the units in Canada, and now the most of units is moving to single rooms. So you have every single baby should be in a single room, unless you have twins, you should be in the same room. So this big space is supposed to be for one infant, one baby, one unit. And it is family, we have the family integrated care, so we respect the family to stay in the unit. So at the back of the room, there is a family, chairs can be converted to, stretched to be a bed, and the mother can stay overnight in the NICU, and the parents are, both of them, welcome to stay overnight. And that will probably encourage more kangaroo care, and also more production of breast milk, and family integration to the bedside care. And the room is based to be friendly. Friendly, there is a fridge in the room, there is a TV, and the things that can make the parents feel comfortable or at home while they are staying in the unit. Yes, there is breast pump for sure, provided, and there is a fridge at the back here, just for one infant to store the breast milk and the medication for this infant. So I have nothing to disclose in this presentation, and I have two main objectives. So hopefully this presentation will condense it compared to the previous session, and less time as well. So at the end of this presentation, you will be able to, hopefully, demonstrate the clinical classification of congenital diaphragmatic hernia. I like classification for everything, so including congenital diaphragmatic hernia, clinical classification, based on the behavior postnatally, not based on the fetal assessment or fetal ultrasound. That's a different story. Now, preoperative, I care more about the clinical assessment, how the infant is behaving clinically. And then I demonstrate the preoperative management with the case scenarios. I have few case scenarios just to show how we can design the management based on underlying pathophysiology and severity of the case. So preoperative management can be divided in this presentation into understanding of the basic physiology, again, physiology before everything. Yeah, physiology is important to understand everything. And the preoperative management and the case scenarios. Sorry, the clinical classification, as I mentioned, and then preoperative management with the case scenarios. So infant with congenital diaphragmatic hernia, the same like any sick infant. So if you are working in intensive care, regardless, adult intensive care, neonatal intensive care, or any intensive care, the same like infant with congenital diaphragmatic hernia, if you would like to get an idea about what's going on as a pathophysiology, it will be one of the things in this slide, one or more. So it could be either issue related to hypoxemia or related to hypoxia. So either hypoxemia, infant at risk of hypoxemia, it could be either issue related to the heart or lung. So it could be limited diffusion in pulmonary edema, or could be right left shunt, or limited diffusion also is expected in surfactant deficiency, which might be associated with also the disease. Hypoventilation, if you are not really recruiting the lung very well. Pulmonary congestion, pulmonary hypertension. So pulmonary congestion, it might be, you might have a situation that you should not use the pulmonary vasodilator in congenital diaphragmatic hernia when you have the lung congested. Typically, you may have congenital heart disease associated with left to right shunt, or any other reason like explaining pulmonary congestion. Or pulmonary hypertension as high pulmonary vascular resistance, or VQ mismatch when you have poor ventilation but normal perfusion. And then it could be issue related to hypoxia. It means that you have issue in the systemic circulation, so low preload, low systemic vascular resistance, high afterload, poor myocardial performance, or left-right shunt flooding the lung. Or could be anemia. Now, I think you realize that this slide is reflecting the oxygen delivery. So in this arm here, you have the saturation. So any, like the hypoxemia should be reflected on oxygen saturation, and the other arm is hemoglobin and the blood flow. The three of them is the equation of oxygen delivery. Oxygen saturation multiplied by blood flow multiplied by hemoglobin concentration. So the clinical presentation could be one of the three things: hypoxemia, acidosis, and systemic hypotension. So typically, you may have any infant with congenital diaphragmatic hernia presented with one or more, and the management is different. You may see hypoxemia due to right to left shunt or VQ mismatch or pulmonary hypertension. You cannot manage everything the same way. That's why clinical assessment is not enough. You need to get a detailed assessment. This slide just to remind you about a very important issue here. And the priority to treat pulmonary hypertension is to recruit the lung at FRC, functional residual capacity. So you have in this graph here the y-axis representing the vascular resistance, x-axis is the lung volume, and within the physiologic lung volume, 100 to 150 ml, you have the functional residual capacity. And you have the pulmonary vascular resistance, which is a red curve, is within the normal value, really low. If you have the lungs under-recruited, here we have high pulmonary vascular resistance because the big arterioles will be constricted. These arterioles need traction and the lung to be inflated. When you have hyperinflation, the small capillaries, extra-alveolar capillaries, will be collapsed due to hyperinflation. In this situation, you have also high pulmonary vascular resistance. So hyperinflation of the lung will lead to high pulmonary vascular resistance that's induced. You don't have to use any pulmonary vasodilator for that. And when you have low lung volume, you have also pulmonary vascular resistance high. What you need to do is just to recruit the lung. And you need to get within this small window here of functional residual capacity. And we'll show some case scenarios how to do that. And typically, we'll get more details if you are going to attend tomorrow the workshop. We'll have more time, practical time with clinical scenarios, and more time for discussion, and more time like how to implement that at the bedside and alternatives. So we'll hear from you more questions. And we apologize that today is very tight. We don't have time to answer all of the questions. Keep in mind that assessment of congenital heart disease, you should keep in mind that could be associated with other anomalies. Cardiovascular anomalies might be associated about 36%, and it can be as simple as VSD or can be as hypoplastic left heart. And genitourinary might be associated at about 23%, central nervous system, which is quite rare, relatively rare, 15%. So once we have the infant with congenital diaphragmatic hernia, we'll get the first echo done by a cardiologist or one of our colleagues and neonatologist in hemodynamics. First, we need to rule out like full structural echo to rule out in a congenital heart disease and also to assess the degree of pulmonary hypertension. So congenital diaphragmatic hernia, typically pulmonary related issue or cardiovascular, as we explained, and they are interrelated. So we have the pathology, pathophysiology, and the clinical consequence. For the pulmonary, we have lung hypoplasia, surfactant deficiency, single lung ventilation. So we need to keep these three things in mind when you ventilate the lung. So you can't give the same volume as you give for normal lung. You are now ventilating just single lung. And surfactant deficiency might be associated because of also lung hypoplasia. We are not expecting that surfactant to be sufficient in this situation. In pathophysiology, you have lung atelectasis, ventilation perfusion mismatch, and pulmonary right-left shunt, intrapulmonary right-left shunt. So to get rid of that, you need to inflate the lung. You need to optimize the inflation. And then cardiovascular, we have arterial vascular resistance high or venous vascular resistance. The differentiation between both is really difficult. And for venous hypertension, echo might not be sensitive. We might need to do MRI, cardiac MRI, or in some situations, angiocath. And then pulmonary hypertension, right ventricular dysfunction, LV dysfunction, might be associated as pathophysiology, according to the phenotypes that we described with pulmonary hypertension. Again, clinical is non-specific. Hypoxemia, acidosis, circulatory failure for everything. So if you rely only on your clinical sense and assessment, you will not get into the differentiation of the underlying pathophysiology. So preoperative management, we are going to discuss now the clinical classification of congenital diaphragmatic hernia. So we have like clinically mild, moderate, and severe. Again, that's not really based on the fetal classification. I care more now about postnatal clinical classification. So I have mild type when you have in pulmonary side, the infant on a mild congenital diaphragmatic hernia, usually diagnosed antenatally. It might be, some cases might be presented postnatally if undiagnosed in antenatally. And if the infant detected late or missed and survived without any issue, it means that mild. The infant was significant, severe, might die without the real detection early after birth. So in conventional ventilation usually, and all oxygen indices are within the mild value, and the oxygenation index is less than 10. Cardiovascular, if there is pulmonary hypertension, it could be subsystemic pulmonary hypertension without pulmonary vasodilator. So without any EV using anything, you may have half or two-thirds systemic with good RV performance. You don't have to use any medication for that. Normal systemic blood pressure and stable hemodynamics. And this infant is ready for surgery without any issue and with very good prognosis. Now the issues will come with the moderate and severe. When you have an infant in moderate congenital diaphragmatic hernia, usually require moderate setting of high frequency ventilation, either jet or high frequency oscillator. Minimum pressure usually 10 to 14, OI more than 10 to 15, and most oxygen indices are within the moderate values. As I showed you in the table, there is my acceptable target, moderate and severe values for the AA gradient, oxygenation index, oxygen saturation index. All of these indices, again, I don't advocate to rely on only in separate value for FiO2 or main air pressure. You need to integrate between the patient reaction with what you are giving to the patient regarding the ventilation of oxygen. So you have to rely on indices. AA gradient, oxygenation index, oxygen saturation index, as we described in the previous presentation. Oxygen indices usually in the moderate values, and the cardiovascular usually equal to systemic pulmonary arterial pressure and might need pulmonary vasodilator, and usually respond to 1 to 2 pulmonary vasodilator, either nitric oxide plus low dose of sildenafil. And the expected scenario here, ready for surgery after stabilization. You need to recruit the lung very well, and the preoperative hemodynamics to be assessed, and the blood pressure should be stable. Better not to be on vasopressor, but we have sent some patients on single agent vasopressor to surgery. Good prognosis with appropriate care. Now we'll come to the challenge. When you have pulmonary higher than pulmonary setting, on a very high setting, high frequency, usually the MAP more than 15, most oxygen indices are in the severe values, including OI, oxygen saturation index, AA gradient, and the cardiovascular. We have suprasystemic pulmonary hypertension in this situation, in spite of multiple cardiovascular support. So when you start a nitric oxide, because of pulmonary hypoplasia, we may not get the response as expected, or sildenafil, or whatever medication. Unstable hemodynamics require vasopressors, either one or more vasopressor, and usually more than one. and requires this infant a trained hemodynamic team. So this category here, the mortality rate is high without having a dedicated team, trained team. And from the beginning to the end, from the delivery room, the most expert staff in the unit, typically the neonatologist by our guidelines should attend the delivery for the congenital diaphragmatic hernia. That means the staff on surface, not just a fellow or the resident. And after that, the management should be dedicated by the hemodynamic team for any management of blood pressure or pulmonary hypertension. Requires a trained hemodynamic team. As I mentioned, stabilization before surgery is a challenge, usually require multiple cardiovascular support, and may require ECMO. I know that might be available, but in some situation might require ECMO for you if you are unable to control the case. Otherwise, the mortality rate expected to be high, and the prognosis expected to be poor. And I mean poor, like it's not 100% mortality. I'm talking about less than 50%. Survival. So prognosis, pulmonary hypertension is the primary determinant of mortality. So with the pulmonary hypertension suprasystemic uncontrolled, the infant might die or might actually tolerate surgery, and some of them might develop pulmonary hypertension, significant pulmonary hypertension during surgery. Very good prognosis in absence of other anomalies, pulmonary recovery, when all resources, including ECMO, and are provided, all of the resources, including the dedicated team, survival range between 60 to 80%. That should be your target. If you are really would like to get your survival rate close to the international. Long-term morbidity is considered significant long-term morbidity, including chronic lung disease, growth failure, gastroesophageal reflux, and urinary developmental delay. So now I'll just remind you about the parameters that we classified in the first presentation. So we are using oxygen saturation histograms. So go back to your unit and ask your provider for the monitors to enable the software for the oxygen saturation histograms. It is very helpful in daily basis to be used. AA gradient is very easy, but you need arterial blood pressure sample to get the partial pressure of oxygen. Oxygenation index is also helpful. Oxygen saturation index if you don't have arterial blood pressure. And saturation FI2 ratio. The lower the ratio, the more severity the hypoxemia. VQ ratio, it can be assessed invisively by radioactive isotopes that might not be available everywhere, but we designed software available, and you need to apply oxygen reduction test, and we'll show you that tomorrow during the workshop, how to use the online tool, online software, artificial intelligence, to estimate non-invisively the ventilation perfusion ratio or mismatch. Sorry. And brain oxygen saturation by NIRS also can be considered. If you calculate the VQ mismatch, also you can get an idea about right to left shunt. Typically, less than 10% is your target, that's physiologic, normal. 10 to 20 is mild or moderate, and then severe. When you have more than 20% right to left shunt, intrapulmonary right to left shunt, it means that you have significant lung collapse. So preoperative management on the first part or the third part or the third category of this presentation to speak about the preoperative management according to some case scenarios. So we mentioned about mild, moderate, and severe. So I'll give you one case scenario for each category. So we have now mild congenital diaphragmatic hernia, term infant, and all of these are real cases from our unit. Term infant was congenital diaphragmatic hernia diagnosed after birth. So this case, one of the rare cases that missed from antenatal screening, or typically there was no good antenatal screening, or there is no antenatal care. So mom skipped or did not show at the time of antenatal ultrasound screening at 18 to 22 weeks of age, of gestational age. So term infant was congenital diaphragmatic hernia. This infant was detected in the ward based on the clinical assessment. The nurse or the physician, the pediatrician, did not hear a good air entry. With mild tachypnea, they did X-ray, and the X-ray showed congenital diaphragmatic hernia. And this infant admitted to ICU initially on CPAP, PEEP of 7, volume of 3.5, little bit lower because, again, it's single ventricle ventilation. FiO2, 0.7, 70%. OI, oxygenation index of 10. And saturation, FiO2 ratio, 122. The lower the ratio, the more severe. And you have the echo, as you can see here. It's mild tricuspid jet. Is very mild flattening at the end of systole of the interventricular septum. That's not that severe, and this infant did not require any pulmonary vasodilator, and that was just with the first day of life echo. So that's also still reflecting the postnatal transition. So we have subsystemic pulmonary hypertension responded to lung recruitment only without pulmonary vasodilator. But this infant still on 70%. So that is high, more than 50%. Still, that's empirical oxygen support. Remember the 3 categories. You have to define yourself. Are you empirical oxygen prescriber or physiologic oxygen prescriber? So this still requiring too much oxygen, so I need to recruit the lung. This infant was breathing for some time. That's why the intestine is full of air. So we need to deflate the intestine from air, and we have a strategy, maneuvers to decompress the intestine, muscle relaxant, infusion or boluses, good size 80 tubes, there is no leak, and then cautiously recruit the lung. So you need to do these steps, and you get the lung recruited and the intestine deflated. And we needed for that PEEP increased from 7 to 9, volume increased just to 4 ml per kg, and oxygen requirement now 30%. And OI is just 5, that's very mild. Saturation, FiO2 ratio is around 316, which is good. So now I consider that as physiologic prescription of oxygen. Now we have the moderate case, term infant with term infant with moderate congenital diaphragmatic hernia. And why moderate? So I have this X-ray, and we just had these, like the next 2 cases recently in our unit. Initially on high frequency jet ventilation from the beginning, PIP of 29. PEEP, we are recruiting the lung on jet ventilation is different from oscillator, PEEP, not MAP. And PEEP of 7, initially FiO2 of 60% or 0.6. OI, oxygenation index of 11. Saturation, FiO2 ratio of 155. And pre-post-ductal saturation difference, 10%. And BA, CO2, 58. So that's typically suprasystemic. You can see the right side is more dilated compared to left. The septum bows from right to left. At the end of systole, you can see the septum paradoxic moving from right to left, and the right ventricle is much more dilated compared to the left ventricle. So that's the reversed ratio. The left ventricle is crescent, and the right ventricle is almost circle. So that's suprasystemic pulmonary arterial pressure, and the PDA was right to left, and also PFO. So this suprasystemic pulmonary arterial pressure was good performance, which is consistent with category or phenotype number 1, right? It is pulmonary hypertension, but without RV dysfunction. But is the infant still requiring high oxygen? Started nitric oxide with no response. Then added merinone up to 0.6. Then blood pressure, as you can see here, 43, 21, mean of 33. Estimated systemic vascular resistance, 65. So do you remember this low or high systemic vascular resistance? Low or high? Low? Raise your hand if low. Thank you, it's low. So acceptable between 100 to typically 150, but down to 100 without significant drop trending down of the blood pressure is acceptable. So 65 milliliter mercury per kg per liter per minute of systemic vascular resistance is low. And why blood pressure dropped? Most probably is iatrogenic. So sometimes you are using medication to help, and we are just getting the side effect. So the blood pressure dropped in this case, consistent with pulmonary, systemic vasodilator physiology. So started or norepinephrine of 0.05, and the blood pressure improved with such low dose of norepinephrine. So it's still empiric. We are not really did a good job yet. I'm not like talking about myself, but like the team work. So we haven't done a good job. We need to work more to get the FiO2 down before surgery. Interventions, what we did, maneuvers to decompress the intestine, muscle relaxant, infusion, then boluses. I have to mention that the nursing care is very important. To get all of the maneuvers done well, the nursing ratio for sick infants with congenital diaphragmatic hernia is 2 to 1. 2 nurses to the bedside, not even 1 to the bedside. 2 nurses because this infant might need multiple maneuvers to be done at the same time. And 2 expert nurses, the top nurses in the unit, to get the plan applied successfully and the infant recover from the acute stage. Mild good sedation, fentanyl infusion might be used 2 to 3 mics per kg per hour. The midazolam might be added, but it's better to be avoided. And muscle relaxant, as I mentioned, is very effective to get the intestine decompressed, because with movement you may get the intestine full again of air. Good size ETQ without leak, lung recruitment, and PIB of 33 increased to 9. So increased from 7 to 9. So we have now partial improvement. So that's the X-ray. Compared to the previous one, you have some inflation, but not sufficient. I still have the oxygen requirement is much less now, but is much less now, but I used to increase now the PEEP to 11. So on 9, did not really improve well. When I increase the PEEP to 11, see the difference. So that's the lung, the right lung is inflated, might give you an impression that could be overinflated, but even the parameters did not show overinflation of the lung, because you have good oxygenation. When we did the echocardiography, the feeling was good, so there is no significant impact on venous return, and OI was just 6 of milrinone, so we discontinued the unphysiologic medication used, and norepinephrine was also discontinued, blood pressure improved, and we just continued on nitric oxide. So that's successful recruitment. So we moved now from the first stage of non-physiologic or empirical to physiologic, lung recruited, and with less medications, and the pulmonary artery pressure improved only with the lung recruitment. Nitric oxide did not make a difference in this case. So that's physiologic oxygen support. Physiologic, so the person who can reach that is a physiologic oxygen prescriber. So in this case, I think you recognize that we have the phenotype, first phenotype of pulmonary hypertension. When you have dilated right ventricle suprasystemic pulmonary artery pressure, what with maintained RV performance. In day 3, before post-surgery, so this infant went surgery, and this is the X-ray after surgery. You may actually not recognize this infant underwent congenital diaphragmatic hernia repair. And you can see now for a chamber view, the beta-femoral valley is shunting, or maybe the ASD shunting left to right, and then the septum is now curved and nice, and there is no evidence of pulmonary hypertension, and nitric oxide was off. 3 days post-surgery on mechanical ventilation, just conventional PEEP of 7, volume of 4 per kg, and room air FI2 of 21%. So this case was just last week in our unit. That's moderate case. Now we need to move to the severe case, the challenging case. We have 36 weeks with congenital diaphragmatic hernia diagnosed antenatally, and as you can see here, you have significant bowel, and you have part probably of the spleen in the chest, and you have initial ventilation, high frequency jet ventilation, PIP of 26, PEEP of 7, FiO2 of 0.9, 90%, that's really bad. OI of 16, and saturation FiO2 ratio of 94, pre-ductal, pre- and post-ductal saturation difference 10%, and CO2 of 58. Still empirical, that's not good. We haven't done a good job yet. So we need to get the good job. Now look at the echo. Echo, the right ventricle is significantly dilated, compressing the left ventricle. So we may expect actually the systemic circulation and the left cardiac output to be affected because of significant compression. And it's not like perfect performance. You have TR jet, which was significant and reflecting suprasystemic pulmonary circulation, dilated, impaired RV performances. It started on nitric oxide with no response again, which is expected in a lot of cases of congenital diaphragmatic hernia. Then added milrinone of up to 0.75, we usually start at 0.3. And then we started sildenafil, or the team started, not me. And the blood pressure dropped with the systemic vasoresistance calculated 67. Again, it is low. So typically, when you use milrinone, sildenafil infusion, both of them are vasodilators. So we may expect issues, iatrogenic issues with low blood pressure. So vasodilator physiology started again with norepinephrine. When you use a medication as vasopressor, use norepinephrine. Dopamine as a vasopressor, you need higher dose. and again might worsen the pulmonary vascular resistance. We don't advocate now to use dopamine as a support in such a situation. Norepinephrine might also help with the pulmonary hypertension. So interventions, what we did in this case, as you can see, from 1 to 7. Maneuvers to decompress the intestine as usual, muscle relaxant infusion, then boluses, good sedation with fentanyl infusion, 2 to 3 mics, as I mentioned. Lung recruitment is the most important step. PIB of 33, PEEP increased to 9 and was partial improvement. Added sildenafil 0.5, as I mentioned, infusion. That was intermittent doses after infusion. Maintain duct open in this case. As you can see here with the ductus is right to left. It's a pulmonary artery with the 3 branches. The right branch, left branch, and the PDA. You can see the flow is blue away from the root. It is right to left. And right to left in this case is helpful. It's good to see right and left. And in this situation, it is deflating the high pressure from the right side and helping also sometimes the systemic circulation. So this extra blood is added from pulmonary to systemic. And we recommended if the PDA in this typical scenario closes, we consider prostaglandin to keep the duct open. So one of the strategies here to consider prostaglandin to keep the lung open before and during surgery. So the lung was recruited or partially recruited, and PIB now of 42, PIB of 9, FiO2, at least less than 50% or 0.5, OI is 14, because we are now dealing with very challenging case. This infant went for surgery the day that I left Canada. So this infant went for surgery and again was successful. Went for surgery without Merinone, without norepinephrine, just on nitric oxide and sildenafil. So these are the 2 medications that used, continued. Lung was recruited and less than 50%. Anesthesia accepted and the surgeon accepted to operate and was successful. So we consider that physiologic oxygen support. We have less than 50% reasonable OI compared to the previous one. And in echo you can see the lung, after lung inflation, the RV performance, and the filling of the heart was much better in this case. And as we described the phenotypes in the previous presentation, this phenotype number 2 was RV dysfunction. And in this case, Merinone was used just transient period of time. Once the RV improved, you don't have to continue Merinone forever or during surgery. Once the RV performance improved, just to wean or discontinue, because you may get side effects from the medication if you continue without good indication. Now we have the conclusions to our presentation. Management of congenital diaphragmatic hernia requires a trained team on intensive respiratory and hemodynamic support. Without having such dedicated trained team, your outcome might not be as expected. Cardiovascular support is the best to be managed by a neonatologist trained in hemodynamics, because he's at the bedside, he's integrating not only echo, near-field spectroscopy, clinical parameters, everything at the bedside. For sure, we need to rule out also from the first echo reviewed by pediatric cardiologist any antenatally missed congenital heart disease. Last conclusion, proper lung recruitment is always a priority. That's why the next presentation for Dr. Alvaro, he will discuss lung recruitment preoperative and in the delivery room. Thank you very much.
And now the presentation. Okay. Now the presentation is by Professor Robin Alvaro for postoperative care of CDH from operating room to home. Thank you very much, and it is very nice to meet you and Yasser after COVID, to meet you physically. Thank you very much indeed. Good. Okay, the floor is yours.
Thank you for, again, for the invitation to present today. So what I'm going to do now, I'm going to try to convince you that having a protocol for management of diaphragmatic hernia in your unit is a major step to improve mortality and decrease morbidity.